Thank you, Dr. Vasanta and Dr. Krishna Prasad. Honored to be speaking in this session, chaired by two such great teachers and people who are so much interested in teaching. And thankful to the AIS for this opportunity to meet you all and to talk to you on these important aspects. Evaluation is the key to successful and appropriate management. And these conditions you would encounter as short cases, as long cases, and in your theory exam. So you need to know about the evaluation of these patients. We begin with evaluation of ptosis. As anywhere else, a good evaluation begins with a good history taking. You need to know the age of onset to differentiate between the congenital and the acquired ones. You need to look for the factors which might have brought about this condition in acquired cases. You need to look for the variability of the ptosis, which may be as a result of the jaw winking phenomenon or as a result of a condition like myasthenia. And then you need to have a family history, as we know that the congenital ptosis does tend to run in families, and the relevant past history, particularly with regard to previous treatment. Evaluation should begin with a general physical examination, which may hold a clue to the cause for ptosis in acquired cases, and for the same reason, neurological examination is important. Ophthalmic evaluation, of course, is what we are going to deal with in the next few slides. It is important to assess the visual acuity and refraction, not just as in any other case, but we do know that cases of congenital ptosis tend to develop astigmatism. Many of them may tend to develop an amblyopia as a result of altered stimulus that they get, or they may be a stimulus deprivation in those infants where there is a severe ptosis. The appropriate assessment for management includes the measurements of amount of ptosis and levator action. These two parameters are the most important factors in decision making with regard to the procedure of choice. So palpebral aperture should be measured both vertically and horizontally. You may have horizontal changes in conditions like blepharophimosis syndrome, but the vertical one is important as it gives you the amount of ptosis. So measurement of margin reflex distance is more important than the height of palpebral aperture, as the height of the palpebral aperture may be affected by the altered position of the lower lid as well. So if you measure the margin reflex distance, that is the distance between the position of the reflex with a torch shining from in front and the center of the upper lid margin, that gives you the MRD1. And in those cases where the pupil is covered, you may need to lift it to say that this is negative MRD1. Say this would be if you need to lift 1 millimeter to get to the pupillary light reflex, that means the MRD1 is -1. And then you can grade the ptosis as mild, moderate, or severe, severe being 4 millimeters or more, and mild being 2 millimeters or less. It is important to do an ocular motility assessment in all these cases, as we know that many congenital ptosis have an associated weakness of the superior rectus or the so-called monoocular elevation defect as a result of the development of superior rectus and the levator from the same myotome during development. Also, in acquired cases and the associated neurological condition, you will get the clues on the basis of ocular motility assessment. Okay, then the levator action is the single most important parameter. When you make the patient look down to the extreme down gaze and make him look up, with the frontalis action blocked without altering the position of the brow, you can check the excursion against a transparent scale, and that gives you the Burke's levator action. And in smaller infants, it may also be important to have them against the wall so that they don't move their head either. So make sure that you don't let extraneous factors, and then if you take a couple of readings and average them, you would get the right measurement of the levator action. Now this may be graded as good, fair or poor, and this is a very important input for your decision making on what surgical procedure you want to do. One good way of differentiating a congenital ptosis from an acquired ptosis is the lid position in down gaze. As we know, the muscle, levator muscle in congenital ptosis is a dystrophic muscle. So just as it doesn't lift the eyelid very well, it does not relax very well in down gaze. And when the person looks down, unlike in acquired ptosis, you will find that the palpebral aperture actually becomes larger on the ptotic side, which is a good indication of the presence of dystrophic muscle. Then margin crease distance, which is the distance in the downward gaze between the eyelid margin and the principal crease or the most prominent crease, constitutes the so-called margin crease distance, which must be measured. It is important in congenital ptosis in order to create a similar situation when you operate the pathological eye. You need to have the measurements on the normal side, but also because it is altered in cases of aponeurotic ptosis, where you have an aponeurosis dehiscens and the crease recesses. So that clue to that diagnosis comes from margin crease distance. The tarsal show, which is the show of the distance between the apparent position of the principal lid crease and the eyelid margin in primary position, in straight ahead gaze, is the tarsal show, which again is important in creating an aesthetically similar lid when you operate the other eye. And the Bell's phenomenon is again of importance when you want to assess the safety of the procedure. When post-operatively with ptosis procedures, you do create a lag of ophthalmos. And for the safety, it is important that the person should have a good Bell's phenomenon when he closes the eye. Corneal sensation is similarly important because those with impaired corneal sensation can be a risk for difficulties. And similarly, presence of tear functions. This also is important, as in a dry eye you would land up in difficulties. Presence of abnormal movements, as in jaw winking, and in say a recovering third nerve palsy with aberrant re-innervation, are important to assess. And it is vital to look for all these associations in congenital ptosis, the jaw winking phenomenon, the blepharophimosis syndrome, the superior rectus weakness, and the monoocular elevation defect. You need to look for other causes for occurrence of ptosis, such as a mechanical ptosis caused by a lid mass or a lid edema or a papillary reaction following contact lens use, or so many other factors. So all those factors need to be looked at in those cases who develop an acquired ptosis. And where you suspect myasthenia on the basis of variability and the other features such as presence of ocular motility disturbances and diplopia, which is variable, you need to do a simple test like an ICE test, which will lift up the lid and give you a normal palpebral aperture in many cases, or you may do any of these drug tests. Phenylephrine test is important, more so in acquired ptosis, where you want to assess whether the phenylephrine causes the eyelid to lift up adequately and is an indication that this case will respond to Müller's muscle resection. We'll now switch over to the evaluation of proptosis. Now this is important, as you often get a long case in proptosis. Here again, it is important to have the right kind of history, which is gives you a clue in most cases to the nature of the pathology. Do a good examination and reach a final conclusion with the help of your investigations. The history of patient is important. Age tells you a lot. you know that certain causes will exist only in infants or in young children, and certain causes would only occur after the age of 60 years. So once you know this, your computer has already excluded a whole lot of conditions. And then the symptoms, those that are related to the physical presence of the mass, structural, and the alteration in the physiology that have taken place. The symptoms essentially are either due to the presence of the mass itself, physical presence, or because of the alterations in the function that it has led to. The time sequence is important. We'll talk about that, whether it was an acute or a chronic process. That again excludes a whole lot of conditions. Systemic history holds a clue to a number of conditions which lead to proptosis, number of masses in the orbit. You'll get a clue on systemic examination and at times the family history. So let's look at the temporal dynamics or the time sequence of things. Onset. An abrupt onset, say within a few hours, would normally indicate possibly something very acute like a hemorrhage. Over a period of a few days would possibly indicate an inflammation. Over a period of a few weeks, maybe a chronic inflammation. Or a few weeks and months, maybe a malignancy. Over a period of several years, maybe a benign pathology. So you exclude a lot of things by giving attention to appropriate points in history. Similarly, about duration, we know that certain conditions only can manifest as an intermittent pathology. So once you know that this is an intermittent thing, like recurrent inflammations in a pseudotumor or like leakage from a parasitic cyst, you know that you're dealing with certain conditions. And the nature of progression, which we've already dwelt on. Now, what are the structural disturbances? You would know whether from the nature of the displacement, whether the displacement is straight ahead axial or it is a downward displacement. If it is downward, it would suggest that this is possibly coming from a structure located superior to the orbit. If it goes out, it is possibly indicating something coming from the sinuses and so on. And then the various kinds, you must elicit the history of the sensory changes, pain, numbness, double vision. You must, of course, get the history of other symptoms like dry eye, which may occur with lacrimal gland pathology, watering, swelling, redness, which may be very clear indications of the nature of the pathology, inflammatory or stasis or whatever. And associated systemic conditions like lymphoma and like thyroid disease often hold the clue. Now let's look at the examination. It's important to do a good ophthalmic examination and a good systemic examination. First, the general assessment, you need to have the status of the patient. Many patients with proptosis, say a patient with cavernous sinus thrombosis or a mucormycosis, may have an intracranial involvement, alteration in sensorium, and so on and so forth. Facial contour and symmetry holds a clue to a number of other pathologies. You have the psychophysical test, psychophysical implying those where patient is giving you the information, such as the visual acuity and visual fields. This is extremely vital, as a number of orbital pathologies would impinge on either the optic nerve or create choroidal folds or create retinal folds or create corneal pathology which alters visual acuity. And this is what you need to constantly monitor, the acuity as well as the field. And one of the earliest manifestations of nerve function alteration may be color vision. So these are important assessments, and of course the extent of alteration, whether of motility, whether it is restrictive due to a tumor or whether it is paralytic due to involvement of the nerves by a malignancy, you would also need to assess. A force duction test is an important clue to whether the pathology is restrictive or paratic. And then presence of retraction, presence of ptosis will tell you their own stories of what the pathology may be. And it is important to look at all these clues. If you have a congestion of this kind with dilated episcleral vessels, you may know that you may be dealing with a carotid or cavernous fistula. And intraocular pressure often tends to increase in diffuse orbital pathologies such as the thyroid eye disease. So you would get important clues to your diagnosis, and these are important aspects for management as well. Pressure signs must be looked for in the fundus, which we spoke about, measurement of exophthalmos, globe displacement. It is important to measure the exophthalmos. Simple Duty's one, which is like a scale, can also be used, but if you have a Hertel's exophthalmometer or one of its variants, you can get an accurate reading of the protrusion and its progress with time. But it is important at the same time to do a reproducible reading every time, keeping this at the lateral canthus, having the same bar reading, and each time having the comparison with the same bar reading. You also need to assess the by palpation. You need to see whether there is a raised temperature, whether the tumor is hard, whether it is compressible. The compressibility is tested by orbital tonometry and tells you that you are possibly dealing with something like a hemangioma, which compresses easily, or a malignant tumor which does not compress at all, where the orbital tension is raised. And things like varices, you can do a Valsalva maneuver and you will immediately see the increase in the size of the lesion, and you would know the clue to possible diagnosis. And auscultation can be useful in keratoco-cavernous fistula, where you will get a characteristic machinery murmur. And systemic examination, such as the presence of huge cafe au lait spots all over, gives you a clue to a plexiform neurofibroma leading to proptosis. Need to exclude pseudoproptosis, as in globe enlargement, as in ophthalmos, high myopia, lid retraction giving you false appearance of a proptosis, or contralateral enophthalmos suggesting that there is a proptosis. I'll very briefly mention the lab investigations, because some of these will hold a clue to a parasitic infestation or an infection, and so on and so forth, and the various investigations which need to be done. Plain X-ray orbits were important but have been largely supplanted by the use of CT scan now. You need to be aware of the basics of what the Carlwell's view, Waters view, lateral view, and the optic nerve view are, optic canal view. These are the basic radiological views that were taken, and the information that they give you regarding the generalized enlargement, presence of calcification, presence of enlargement of the superior orbital fissure, or the optic foramen, either a uniform one or an irregular one. These are the same clues that you can get on CT scans as well. Hyperostosis or osteolysis, diffuse or localized, may give a clue to the nature of the pathology. I'll be avoiding CT scan and MRI and ultrasound, as imaging will be covered by Santosh. Orbital venograms were a useful technique earlier, or angiograms, but now they've been largely supplanted by the use of MR venography or MR angiography, which give you important diagnostic information, and those must be used in appropriate cases of vascular tumors. They are suspecting AV communication, you may need to do a digital subtraction angiography. And orbital biopsy, of course, is the one most important thing. You may do a needle biopsy, incision biopsy, or an excisional biopsy where the mass is available to you. Special stains are important. Immunohistochemistry is important. And Dr. Kaustubh is going to speak to you about all these. We'll just run over the various lesions of different age groups. In infancy, you may have the various congenital anomalies like this encephalocele, teratomas, and you may have capillary hemangiomas. In children, you may have the various inflammatory disorders such as the preseptal cellulitis, orbital cellulitis, subperiosteal abscesses, or even fungal infections such as aspergillosis. Parasitic infestations are common. Myocystic sarcosis is one of the commonest. causes in our country. And you may have the various orbital tumors such as dermoids, which you see here, or a dermolipoma, an optic nerve glioma in young children up to the age of 10 to 15 years with an axial proptosis, loss of vision, plexiform neurofibromas, and the various vascular lesions such as capillary hemangiomas, cavernous hemangiomas, orbital varices, lymphaticovenous hemangiomas. In adults, the spectrum becomes different. You have the same infective pathologies that we spoke about, orbital cellulitis, but mucormycosis in immune compromised individuals can be life-threatening and must be diagnosed early enough. Then aspergillosis, as in children when we spoke about, this can be a relatively chronic fungal pathology. Non-specific orbital inflammations or the orbital pseudotumors may have 4 different types, either a diffuse process, a myocytic process, that involving the lacrimal gland or involving the orbital apex. So this is a pseudotumor manifesting as a nerve palsy with a thickened muscle responded with steroids, which is the characteristic of non-specific orbital inflammations. Parasitic infestations in their various forms, either with ocular motility restriction or a subconjunctival abscess or a hydrated cyst. Then thyroid exophthalmos is of course one of the most common causes, thyroid orbitopathy. Then you may have the various lacrimal inflammatory lesions as in sarcoidosis, or you may have thyroid orbitopathy, malignant forms, vascular lesions of various kinds, including cavernous hemangiomas, caroticocavernous fistulas, orbital varices, and the various tumors which may involve either the lacrimal gland, this is the one in sarcoidosis, this is a pleomorphic adenoma, and adenoid cystic carcinoma is a relatively common malignancy occurring in relatively younger patients around 20, 30 years of age, and the various other neoplastic ones like schwannomas, meningiomas, lymphomas, NHL, and those which come from the surrounding structures such as the sac, such as the eyelid or conjunctiva, or those coming from the sinuses like the frontal or frontoethmoidal sinuses or nasopharynx. The last part that I'll be covering will be the evaluation of epiphora. Now, it is important to understand the basic anatomy when we talk about the lacrimal system. We know the production is either by accessory glands or the reflex secretion from the main lacrimal gland, going with the capillary action to the puncta and then along the canaliculi through the common canaliculus into the sac, where the lacrimal pump pushes it down the nasolacrimal duct into the nose. It's important to know these relationships, the vertical part being 2 millimeters, the horizontal being 8 millimeters. So anything at 9 to 10 millimeters is common canaliculus, and beyond that you have the sac with all its dimensions. It is important to think of a watery eye as one either having lacrimation, which is a hypersecretion, an epiphora or disturbed outflow, or a disturbance which is due to a lid malfunction, such as a facial nerve palsy, which does not distribute the tear film on the surface well, or you may have a combination of all these factors. So it is important to have all these points in the history. You need to differentiate the pathologies at different ages. You need to pick up whether it has been a relatively chronic pathology or whether it is an acute pathology, intermittent or constant, and what are the associated features and any treatment that has been taken. Examination should include a detailed examination of the drainage system, the tear production system, a good examination of the anterior segment, in order to look for the various causes, either for lacrimation or for obstruction of the lacrimal passages, but it is equally vital to look into the nose because that's where the drainage is taking place, and this is something that is often neglected. So you need to look for ectropion or entropion, you need to look for presence of lid laxity, facial palsy, a medial canthal laxity, presence of puncta are very important to look at. You may often have either a congenital agenesis or a stenosis or a malpositioned punctum as the cause for pathology. So you look for punctum position, but also when you do a slit lamp examination, you look for pathologies like blepharitis, trichiasis, concretions, cysts, which may be causing overproduction of the tears. You need to look for corneal pathologies, height of the tear meniscus, and then once you have excluded all those causes on slit lamp examination, you can actually do the evaluation of the lacrimal drainage. Now, the tests that are clinically used most often include the fluorescein dye test, which is the dye disappearance test, the Jones dye test, the most important one, lacrimal irrigation and diagnostic probing and examination of the nose. So, when you put a little dye in the conjunctival sac and you find that the dye goes through normally, it disappears within 5 minutes, you know that possibly the tear function, the system is functioning well. This amount can be estimated on a 0 to 4 scale. If it does not disappear, if it remains there, then you know that you're possibly dealing with a drainage pathology. What does the Jones dye test do? Jones dye test is indicated only in cases where you're suspecting either a functional obstruction, the passages are patent structure wise or at least partially patent structure wise, but the patient has symptoms. And there it is important to look at the function by either a primary Jones dye test or a secondary Jones dye test. So what do? In the primary Jones dye test, you would put a dye into the conjunctival sac, put a pledget of cotton into the inferior meatus far enough to the position where the opening is present and see whether any dye gets through. If it does, then obviously the system is functioning and doing what it should be doing. So if the dye comes through, the test is positive. But if the dye does not come, there may be two reasons for it. One is that it is taken up from the conjunctival sac, go from the conjunctival lacus and goes into the lacrimal sac, but it does not get transmitted because the pump is not functioning. Or it may not at all be taken up by the lacrimal sac. Now, how do you differentiate these two situations? If the no dye has got through, that's where you do the secondary dye test. Now, if you inject with a syringe and now there is a dye reaching through, there is no dye reaching through, means it was not taken up by the sac. If the dye had gone into the sac, you will find now the fluid comes which stains the swab. So that is how you differentiate with the secondary dye test. And the most important last thing that I am going to cover is the lacrimal irrigation and probing. So essentially what you do is you dilate the punctum with your punctum dilator and use a syringe. You could use a straight one or you could use a cannula which is bent, but straight one also gives you the advantage of possibly getting the same information as you get with a diagnostic probing. So you go through and inject the fluid into the sac. If the fluid passes into the nose, the passage is anatomically patent. This is a simple interpretation. If there is a regurgitation from the opposite punctum, where could the obstruction be? It could either be at the common canaliculus or lower down, beyond the sac nasolacrimal duct junction or nasolacrimal duct. If clear fluid comes and comes relatively rapidly, you know that this is possibly a common canalicular block. If you get mucoid discharge or mucopurulent discharge, you would immediately know that this has come through the sac, from the sac, and therefore the obstruction is beyond the sac. And if, on the other hand, regurgitation is from the same punctum, then you get the information that it is possibly a canalicular block. Now, this can be collaborated by the use of probing. So, if you pass in a probe and you see the distance by which it passes and you measure the amount, the distance through which it has gone through, then you get a diagnostic probing. Now, it is also important to feel what kind of obstruction you get. If your probe passes through freely beyond the sac up to feel the bone, that is known as hard stop. And the regurgitation that you get now will be one information, but at the same time, the distance through which it has passed, if it has gone beyond 10 millimeters, if it has gone 13, 14 millimeters, and you get a hard stop, you clearly know that it has gone beyond common canaliculus and the obstruction possibly lies beyond the sac. If on the other hand you get a soft stop, then you know that it is possibly somewhere short of reaching the bone, and the distance tells you where the obstruction may be. If your probe has only passed 3 to 4 millimeters, it is a canalicular obstruction. If it has gone 9 millimeters, then you know that it is possibly a common canalicular obstruction. So a combination of diagnostic probing and diagnostic syringing are very important clues to the nature of obstruction. And nasal endoscopy is extremely vital to diagnosing and to planning of your surgery, because nasal pathology at times precludes a successful lacrimal surgery. But lastly, the radiological things which give you some information: dacrocystography, scintigraphy and CT scan. Dacrocystography, where you inject a dye and look at the level of obstruction and gives you information regarding a free flow, nature of obstruction, lower end of NLD or beyond the sac, and there are a number of variations of dacrocystography. Dacroscintigraphy, where you just put in a technetium pertechnetate dye and measure by a Geiger counter. This is a physiological test because you are not pushing anything, can even be done in a children, and you can see how far the dye has passed. You can actually visualize the sac area, or transcanalicular endoscopic evaluation is now commonly done. And CT scan will give you about the surrounding bony pathology which may be responsible for the obstruction. Thank you very much. I hope it has covered the aspects adequately. Sorry for the delay.